So I'm just going to talk about a little bit more of the decision making and progress we've made over the years. And Dr. Andriol's talk, fits nicely into this. So I'll always enjoy his take on everything. PSA is obviously the major game changer in prostate cancer if you go over multiple decades. And it was interesting to see that how guidance has changed that. So for example, we saw the percent of males getting PSA screen certainly increased in the early 2000s when the U.S. task force recommended against it. You saw it dip and then eventually rebound as guidance was amended, so to speak. We know that there are modest gains in mortality. There's risks of treatment and overtreatment. And there still is a global trend, especially U.S. trend of overtreating low-grade disease. I won't go through all the screening trials, but mainly just to show that in those exercises of understanding the trials came out of it a lot of ways to make incremental progress to limit the harms of screening and treatment and to maximize the benefits. So let me try to explain all of these. Are some slides from our fellows. I was always interested in this PCBC trial slide just to showing that there are challenges of cancer being diagnosed almost every time you pass a needle into the prostate, but still with efforts to try to be more selective and to try to get clinically significant disease treated. We almost had to go through a traumatic survival of PSA screening a little over 10 years ago when the guidance came out against it. Lots of media press sort of hyping up the harms of screening and treatment. The one that got my attention actually right away was the quote that 1 in 200 men die from prostate cancer surgery. That is a real quote from a SEER Medicare study in the 90s. So by definition, 65 and up. But for my high volume surgeons, that'd be 1 a year. That would be awfully depressing. But it did give us a construct. So like if you go to NCCN screening guidelines, which admittedly are sort of a panel of experts using voting and a little bit of evidence, a little bit of strong opinions. It's a little bit different than AUA guidance, which has structured evidence review. But you go back to that guidance, you do see the main structure of when to screen, who to screen, how to do it, frequency. There just lacked details of how to really get into the updates of that. Fast forwarding 10 years, the guidance is a little more interesting now because there's a lot more opportunities to pull out information and to improve outcomes. So as a baseline evaluation, for example, family history and genetic screening matters. You have all the information Dr. Andriol just reviewed. There's a lot more attention to baseline PSA and how frequency of screening after that. But I have a list of bulleted changes that have evolved, especially in the footnotes of NCCN guidance. The big ones and that we debate is the role of MRI and biomarkers that improve the specificity of screening. One of the interesting committee debates on MRI is the language of it, because they still include that phrase, if available, which gets into the philosophy of guidance panels. So for my personal opinion, an NCCN member institution surely should have access to high quality MRI, and I would say every biopsy should have an MRI unless it's contraindicated for the usual reasons. There's still the thinking that the guidance has to be applicable across the practice of urology, including centers that don't have access to high quality MRI. My take on that is that, well, maybe if we just put the guidance where the evidence says it should be, people will catch up. If someone's in a smaller community, they could take the guidance to their hospital and say, look, we're supposed to have high quality MRI, not just still doing Trust 12 biopsies, which we see all over Texas. And the first thing they do at Anderson is have to go back and basically correct or optimize, is the friendly way to say it, optimize their diagnostic pathway. So we'll see if I win out in the end, but I argue it every year at the committee. The management footnotes, of course, have lots of little caveats on how to use MRI-targeted biopsy, what to do with negative MRI, and of course the litany of secondary biomarkers. He gave you a little bit more detail on that, but I think it's good for all urologists to get to know one that they're familiar with and to use that to supplement, as noted, we'll go through in the talk. TP biopsy, we're going to hear later in the course. I can see that's actually acknowledged as a way to reduce sepsis. And that just kind of reminds me to one of the themes of the talk, as a phrase borrowed from my colleague Nima Navai at MD Anderson. He, as a bladder surgeon who does exclusively robotics in cystectomy, including diversions, he often gets paired against like our chair who does open cystectomy. And probably the way he debates the topic more often is just to say, embrace incremental change, even if it's small. And he'll then outline how that occurs in robotic cystectomy. In prostate, there's a way to think about that. It's more than incremental change. It's sort of aggregate and intermittent change. So if you look at what the task force criticized screening on, it kind of goes into 4 categories. You have benefits of screening versus harms, especially biopsy harms, PSA, repeat anxiety. Yes, there's benefits of treatment, but then there's harms of treatment, whether or not it's mortality, complications, or quality of life. So by inference, sort of any incremental gain in those negative columns sort of increases the overall value of PSA screening, especially if they're not subjected to 1 in 200 odds of dying from an intervention, for example. We looked at that in the Premier Prospective data. We were actually in the data for a learning curve of robotics type of paper, but we could easily see the mortality statistics were more like 1 in 300 for opens in this large network of private hospitals. But even with follow-up data, it was well over 1 in 1,500 range for robotic prostatectomy. There actually are some lap prostate in Premier Prospective. With Andrel no longer operating, I wonder if that whole column will just fall off, right? Who's left? It always showed up as 1%. I was like, well, that must be Jerry's statistics. I like this algorithm from UCLA years ago that just showing how there's sort of interaction with imaging and biomarkers, mostly doing a pre-biopsy MRI. If there is not an ROI, observe versus look at their density, et cetera. If there is one, TP biopsy, looking at density, strong family history, et cetera. If you have a lesion, obviously move with a fusion with systematic TPs. I use the precision point. I think we're going to hear more about that tomorrow. This was our first look at it when we routinely subjected surveillance as well as prior negative biopsies to just repeat trust biopsies. You would get about a 15% yield of clinically significant cancer. When you use a transperineal template or a fusion directed, you essentially doubled that. We initially did that as a cost analysis because we did all the specialty biopsies, TP or fusion in the OR with some mild sedation, so that ramps up cost, but you're doubling the yield. And hopefully you can trust the negative results and intervene less often down the road for those folks. So this is just an example of incremental change. Before I started this JU Open Plus that Fernando mentioned, I started Compass for the BGOI system, another open access journal. And in our first 3 years, it's just all the topics of incremental change of people trying to improve, publishing papers on improving biopsy methods, innovation with surgery, technical improvements, perioperative as well as operative with the surgery, for example. So if you conclude on the screening, what are we doing better about prostate screening? You've got better guidance about when to do it, how to involve genetic risk, et cetera, imaging, secondary biomarkers, reducing morbidity, et cetera. Briefly, I'm going to interlude into PSMA PET, and then we're going to come back to the other biomarker talk. This is kind of what we're seeing in real time in the clinic now that PSMA has been out for a couple of years, as people come in with large locally advanced lesions that look resectable. And traditionally, 2 years ago and before, we would just counsel on options, and if they wanted surgery, we would do that, and then you sort of deal with the pathology and the adjuvant versus salvage radiation to follow. Or they would go for radiation and extended hormones. Now we're PET imaging essentially everyone unless we get an insurance denial. This is an example of someone that looked good until PET scan where he had 5 nodes all over the place, including 1 periaortic. So that does lead to kind of going over what is this algorithm of clinically positive nodes. You know, when I was a resident, it was as simple of, you know, if you had high risk localized disease, you went for local therapy, but if you had a conventionally detected node greater than 10 millimeters, they were sort of considered metastatic and they all just went on permanent hormone therapy. Now under clinical node positive conventional disease, you do have a history of research in that. The radiation literature is a lot more solid because they've done really studies of radiation with or hormones alone, or the POP-RT trial that looked at dose escalation. With surgery, you have a lot of retrospective series showing some benefit of surgery with clinically node-positive disease, but as part of multimodality therapy in most standpoints. So the true prediction of that is really not known. And then you enter into this sort of clinical molecular detected MRI disease in between true localized disease and conventionally positive disease. And so what are the arguments? In fact, we still think control of the primary might be valuable. There's a number of studies on even controlling the primary in metastatic disease. The extent of pathologic N1 is certainly prognostic, as I'll show. Extended nodes might reduce, that's one of the hypotheses, the need of hormone therapy over time. PET scan, though, if you looked on the right-hand column, it picks up about 40% of disease, whereas it's over 90% specific. So when it's positive, it's probably real, but a negative PET scan still has, a little bit over a 50% error rate. So that's kind of where we go with PET. In terms of the rationale of then how to use it, I'll just simplify that slide and say that when we do a lot of node dissections, there are sort of familiar spaces we would enter into. I think you have a node talk coming up as well. So the familiar spaces would be obviously the iliacs and the hypogastric. Then the non-familiar areas would certainly be anything up higher than the chain to that or presacral type lymph nodes. So I sort of look at the scans. 1 to 2 positive nodes does have some durability on long-term studies with surgery alone, but 3 or more nodes clearly is more of a metastatic pattern, and then aberrant locations obviously get me, especially recently we saw one that was essentially a perirectal area that you wouldn't normally be able to just wander in and find without some sort of localization. So for the most part, just some of the background information. We've talked about the sensitivity of PET. Certainly having a negative PET is better than a positive PET on outcome studies with PSMA. And here's kind of the sharp breakdown between 1 to 2 nodes versus greater than 2 nodes. So my algorithm is sort of PET scan 1 to 2 nodes, familiar locations, and you need a little bit of the luck. The sort of the hard to quantitate part, it is true that if PET shows 1 to 2 nodes and you operate, you might end up with more. There can be more than meets the eye on that. So there's a little bit of a guesswork on that until this gets refined better. Still, the therapeutic option is why this category remains interesting, because really, despite efforts for decades to improve extended node dissection, it really is not thought to be therapeutic. As an AUA panel type of discussion, it's thought to be valuable for staging mostly high-risk patients and sort of the upper end of Gleason 4+3. So I do a whole lot of NX cases now. If they're favorable intermediate or anywhere in there, they're not getting node dissections at all, really. And then getting back to, I think for time, I'll skip the discussion there. So let me go back to the biomarker part, because I wanted to really get into the comparisons of when we use MRI versus biomarkers. This is just a good representative study from University of Miami, where they had a series of MRI and 4K score cohorts. Certainly if the predicted probability is low versus high, the degree of 4K score matters. So there's certainly some overlap there. But I like this table. It's a busy table, but it kind of gets to the heart of which strategy is going to win out in the end. So they defined 5 different strategies, 4K alone and only biopsy for a biopsy above that, a threshold, MRI alone, and then various combinations of doing both or layering them together. If you look under the Gleason 7 cancers missed, on the right-hand column, you see that as you start either sequencing or basically using both, they had the fewest number of percent cancers missed. So then this is a slide that he developed for another meeting, and then I just added my own opinions on top of that to sort of go to the pro and con of biomarkers and MRI. So the advantages of MRI is that you certainly have level 1 evidence on the trials behind it now. Targeting certainly gets you optimal grade and the ability to do genomic testing on optimal biopsy. And it's sort of, I consider it the more definitive risk if they have Gleason X, Y, or Z, and you have, tumor biopsy characteristics, for example. And then the MRI itself helps with treatment planning, whether or not you're going to operate or a colleague would do radiation. The con is obviously the variable access to high quality images, and targeting can obviously miss. And there's, of course, side effects of having to repeat biopsies over time. For biomarkers, of course, you've got broader access, and in theory, the biomarker is the same regardless of the treatment center, unlike an MRI potentially. It does improve specificity of PSA and give you a risk estimate, but having a risk estimate is really never the same as having like a Gleason 8 in front of you in terms of what to do next. So you see the cons and all that. So in terms of Practice application, the task in your clinic is to work with your patients and your PCPs to understand the benefits of screening if done properly, trying to incrementally improve all the controversy around it. We've got 10-year progress of imaging, guidelines improvements, secondary biomarkers, so there's a need to acquire infrastructure and skills. So that often is decisions on which of these tasks you like better. I've gone with mostly an MRI first, PSA biomarkers second approach, selecting fusion platforms that work for you. Micro-ultrasound comes into the equation. And then our use of tissue markers is kind of reduced to mostly Gleason 3+4 for cases that need a tiebreaker, just because usually the other tests have figured out most cases. Gleason 6, 10 years ago at this meeting, we talked about genomics for low-grade cancer. Now, for the most part, we trust imaging and biopsy, and we just follow them. And the genomics have moved up a classification, but not as a routine. So just taking you through a quick case as an example of how this gets put together in real time. We had a 64-year-old African-American male who had SBRT for intermediate risk prostate cancer, and how we got there was a screening visit, a PSA that included a high density of 0.24, MRI with no lesions, but with enough density and ethnic risk, we went and did a select MDX, which is my favorite secondary biomarker, that showed 47% overall risk with 20% clinically significant. So that did lead to a discussion and options, and ultimately I did a TP biopsy on that and had 6 cores of grade group 2. So then he starts over in our clinic where we do multidisciplinary clinics. So he comes back with me now with a diagnosis and a radiation oncologist. He preferred a radiation approach. They actually did the Decipher score there. That's kind of one of their new routines, is if they're Decipher low with favorable intermediate risk, they'll actually drop the ADT and just do straight SBRT or a similar full dose radiation. Then they like fiducial, spacer, all the usual topics. So that was his anterior disease platform. If you look at our paper from JU a couple years ago, that's the most notorious part of the prostate where imaging only captures about half of it. So I usually like my surveillance patients to have at least one anterior sampling somewhere in their monitoring, sooner than later if I'm the starting doctor. That was the Decipher score I mentioned. And then I think we're running low on time, but those are just sort of the house notes on what we learned in that case. One exception to the rule that I leave that up to remind me of is, what if this patient were 75 and probably is not supposed to get screened? Those are the patients where sometimes I will do the marker first. If it's negative, maybe stop. But if they're in a screening age, tends to be more image-based. So PSA, of course, is the anchoring diagnostic test for prostate cancer, the game changer, and it was almost taken away from us, so to speak. But a lot of hard work to refine how to use it best, how to use imaging and secondary biomarkers, which now are on the guidelines and keep changing every time we discuss it. And then PSMA is in real time changing high-risk, locally advanced disease. The more clearly early metastatic cases are getting reverted to systematic therapy or systemic therapy with likely, sort of a radiation plan at a later date with select use of surgery. All right. Thank you very much.